It's a great honor to be here today. A lot of my personal and professional heroes are in the room right now. So it's both humbling, inspiring, and my goodness, intimidating. This front row I've been sitting behind, I don't know if you saw it. If anybody has the power to kind of make the rain stop right now, I'm pretty sure they could do it. But we'll go on. I'll try to speak loud enough to speak over the monsoon. So I'm a psychiatrist. I work with the Department of Mental Health at the Massachusetts Mental Health Center. It's a community mental health center located right here in Boston. I want to talk about our Wellness and Recovery Medicine Center, which is a health home for people with serious mental illness. Briefly define serious mental illness. What I'm talking about is people that live with severe and persistent psychiatric disorders such as schizophrenia, bipolar disorder, severe and persistent depression. And a health home is a model of care to kind of provide wraparound and integrated services for this patient population. So I'll start by telling you the story of Mr. B. So Mr. B is a 33-year-old man who's lived with schizophrenia since his late teenage years. His 20s were marked by repeated psychiatric hospitalizations. During that time, he also developed obesity and was diagnosed with diabetes. His diabetes was well controlled while he was in the hospital, but when he returned to the community where he was homeless, he had difficulty maintaining his diet, difficulty obtaining and taking his medications, difficulty following up with his psychiatric and medical providers, and eventually he was lost to the system. He stopped showing up to his appointments, he fell out of care. His providers were fragmented across several systems, they didn't really talk to one another. His diabetes significantly worsened. He developed painful burning in his foot from peripheral neuropathy, and his kidneys started to fail. This is a story about a person with complex medical, psychiatric, and social needs that our current healthcare system has a challenging time meeting in an effective manner. This is not an uncommon story. Now imagine that we had a healthcare system for Mr. B that was easy to navigate. Imagine we had one that understood all of his needs and challenges. Imagine there was a system that would work tirelessly to decrease barriers to his care. Imagine he could walk across the street from where he's living in a transitional shelter, go into his community mental health center, where his primary care provider also works, and have a treatment team that sees him as a whole person, that doesn't separate his body from his mind, that works together with one common shared treatment plan to address his diabetes, to develop this treatment plan with community supports, and to substantially lower his risk of dying early from a preventable and treatable medical illness. Imagine. That's how we envision care at Massachusetts Mental Health Center for our patients. That's what we're working to provide with our medical home, and that's how we're helping Mr. B. Some of you may know this statistic. On average, people with serious mental illness die 25 years earlier than the general population in the United States of America. This is a shocking statistic. When this research was published in 2006, it made the front page of the USA Today newspaper. This is not a healthcare issue solely. This is a social justice issue. Now, people with serious mental illness, they're a stigmatized and marginalized population. Progress on this has been slow over the past few years. I often wonder if that USA Today article said something like, suburban soccer moms are dying 25 years earlier than the general population. What might have been the response to that? I'd say that the minivans would have circled around this problem, and we may not be having a talk today about that. So what do we know about serious mental illness and death? What causes people with serious mental illness to die early? Well, most of these deaths, over 60% of them, are actually from medical illness. And the number one cause being a primarily preventable and treatable heart disease, cardiovascular disease. What else do we know about medical illness and mental illness? We know that people with mental illness are more likely to have medical problems, get them when they're younger, and then die sooner once they have them. So before I talk about what we found as far as health numbers at Massachusetts Mental Health Center, let's talk about how healthy Massachusetts is. So every year they do an annual health survey that kind of pits every state against one another, and they look at a variety of health outcomes. We're the fourth healthiest state in this country, right? Congratulations, Massachusetts, we are really healthy. If you look at this, we're in the top 10 if they look at a number of different measures, obesity, smoking, low rates of diabetes. It's fantastic. Now, if you compare that to Massachusetts Mental Health Center, If you look at our numbers, we're approaching 50% for obesity, for smoking. Our diabetes rates are twice as what's seen in Massachusetts. And so let's say for that nationwide survey, we say, all right, we're going to have Massachusetts be represented by the people at Massachusetts Mental Health Center, the people we serve there. What do you think happens to our ranking? We dive bomb. We're dead last, and this is by a wide margin. And I was going to make a joke about Alabama, but I promised I wouldn't. But we're at the dead bottom, and it's not even close. So there's this huge gap there. And how do you address it? What are causing these kind of gaps? Well, there's a lot of complex reasons for this. There's not a single problem causing all of this. Sometimes it's psychiatric illness itself. It's the lifestyles. It's social determinants of health, of course. It's the medications we use to treat these illnesses. But let's talk about the healthcare system challenges for a minute. So our current system of care is fragmented. If you have a mental illness and a medical illness, your care is spread all over the city, and it's different silos. Your care is poorly coordinated. It's hard to access. Once people with serious mental illness get into care, there's study after study that shows that the care they actually receive is worse than everybody else that gets into care. They get fewer preventive services. They're less likely to be offered diet and exercise advice and smoking cessation interventions. So how do we combat this? From a systems level, there's been a lot of interest in integrating care, bringing primary care and mental health care together in a way to really combat these problems. You've heard about collaborative care, you've heard about patient-centered medical homes. The issue for people with serious mental illness is the system they're attached to is the mental health system. So the idea is that one of the best places for them to get their care is within the mental health system. So you take a community mental health center like Massachusetts Mental Health Center, and you bring the primary care into the fold. And you don't simply co-locate them. You have to bring them together and work in a coordinated manner. It's not enough to just have people in the same building. They have to be working together as a team. So we took this health home, there's the cheesy graphic, that's a bridge. So we took this health home concept and we wanted to apply it at Massachusetts Mental Health Center. When I got there 3 years ago, the groundwork had already been laid by a lot of visionary people within the Department of Mental Health and at Massachusetts Mental Health Center already to bring primary care into the fold. So through the Kraft program, I was lucky enough to get a seat kind of on the ground floor in the leadership team that was responsible for kind of developing and implementing our health home concept. So what does it look like, our health home? So here's our schematic of what the health home at Massachusetts Mental Health Center looks like. So if you're a new patient, you come in, you start at the left side of the slide there. You get an integrated intake and assessment. We want to know what kind of psychiatric needs you have and what kind of general health needs you have, and we do a general health screen at that time. We have traditional mental health services. We also have a lot of specialty mental health services. And then we have our WARM Center, our Wellness and Recovery Medicine Center. We provide wellness services to the whole population. We want to be responsible for everybody's general health and overall wellness. And then we also have direct primary care services that people can enroll in. So those in the green there, those are kind of our core components. So our primary care clinic has been up and running for about a year now. It's a fully functioning on-site primary care clinic that's run through a partnership with Brigham and Women's Hospital. It's led by our fantastic primary care doctor, Dr. Gail Levine, who many of you I'm sure know. So over the last year, we've enrolled 300 patients in primary care on-site at Massachusetts Mental Health Center. The other aspect of the WARM Center is our wellness services. And this is where we're targeting population-wide issues such as obesity, diabetes, and smoking. And that's led by our great nurse manager, Veronica Besançon, who's one of the best motivators for health change I've ever met. And she can kind of change you from pre-contemplation to action with just a look. She doesn't even need to talk to you. She just looks at you and you're like, all right, I'll stop smoking. You need somebody like that on your team to make these systems work. So we have a yoga group, we have a nutrition and cooking group. So we've got all these groups to kind of help people work towards these health behavior change. Now, I'll spend a little bit of time talking about the health screening that we do. So we kind of imagine this general health screen we call our health and wellness snapshot. It's a 2-page form, front and back. We wanted to be as short as possible. We wanted to focus on the really high priority needs for our patient population. So we asked them, do you get primary care? When was the last time you got it? Have you gotten all these health and preventive maintenance services that you should have gotten right now? What kind of medical problems do you have? What do you do for diet and exercise? Do you smoke? Do you drink alcohol? And then on the back side of that, we take vital signs, we get their weight, we check their cholesterol, check their blood glucose, because cardiovascular morbidity and mortality and risk factors are a huge issue in our patient population. So that's our screen. Ideally, we want to get it on all 1,100 people we serve. We want to get it annually. That's where we found out the numbers that I showed you earlier. And we use that for two purposes. The first one is we use it to kind of know what we're dealing with, know what the high priority areas are, so we can design services to intervene on those. The second way we use it is through a little bit of population health management. So this is on an individual level. So we can take all the numbers that we have, pull them together, and find out our risk list. So if you look here, here's our table. We have hemoglobin A1Cs to find out who has like the worst diabetes at Massachusetts Mental Health Center. So we highlight those. That helps us identify the highest risk clients that we have. We can then notify their care team and say, oh, hey, did you know, here's the numbers we found. We can evaluate the care that we're getting. Do you have a primary care doctor? Where do you get care for your diabetes? Are there any gaps or barriers that we're not addressing? And then we can really engage that patient in a personalized approach to these issues, whether or not it's lifestyle modification, get them connected with our group programming, and then we want to monitor outcomes and find, is this changing, and then kind of repeat this process over and over again. So that's what we're doing right now. There's a lot of future directions we're going to take, and we've already embarked on some of these. So I'll comment on a few of these. The first thing is peer wellness coaches and navigators. There's an emerging literature that really shows that people with lived experience of serious mental illness can help one another with coaching, lifestyle, behavior changes. So we have support to be able to hire a few of these folks to kind of come into the fold and really help with our health and wellness services. The second item there, shared decision-making, health education, self-management. These are person-centered empowerment strategies that we want to really make structured and systematic in the way we deliver care. So we're working on kind of structured interventions that highlight those empowerment strategies. The next one there, Massachusetts Mental Health Center, we have a bunch of trainees there. We've been a training institution since we started 100 years ago, and we really want to figure out how can we instill these values and this training in the next generation of primary care and mental health providers. And so we're developing programs to really teach the trainees about these things. The next one there, smoking cessation. You could argue that smoking is probably the primary contributor to a lot of the early mortality that you see, and it's an enormous problem. You saw the number, 50% of our patient population are smokers, whereas in Massachusetts, generally, it's almost 17% and declining over the years. For people with serious mental illness, it's stayed steady over the last 2 decades. And so we were fortunate enough to get a grant from the Attorney General's Office, a behavioral health grant, to develop and implement a center-wide, comprehensive, innovative, evidence-based smoking cessation program that we hope will dramatically reduce the rates of smoking at Massachusetts Mental Health Center and go a long way to reducing the premature mortality. And the last one, tracking care utilization, outcomes, and costs. We want to make sure that we're doing a good job from a systems level. It's hard to get this data, but we hope over time that we'll have that data to make the case that what we are doing is cost effective and is saving lives. So finally, on a personal note, I just want to say that I've had the good fortune to be able to continue this work even after my time in Kraft ends this month. I'll be able to continue this. The Kraft program has really given me tools and resources to be more effective in my role at Massachusetts Mental Health Center. And as we're working together in the service of our patients to kind of close that outrageous, that morally outrageous 25-year mortality gap and help people like Mr. B, really pursue meaningful and healthy lives in the community. Thanks for your time.